Varcarolis, Foundations of Psychiatric Mental Health Nursing, 8th edition, Chapter 3, Psychobiology and Psychopharmacology. Key terms and concepts: antagonists, anti-anxiety, anxiolytic drugs; cholinesterase inhibitors; circadian rhythms; first-generation antipsychotics; hypnotic; limbic system; lithium; monoamine oxidase inhibitors, MAOIs; mood stabilizers; neurons; neurotransmitter; norepinephrine and serotonin-specific antidepressant, NASSA; pharmacodynamics; pharmacogenetics; pharmacokinetics; psychotropic medication; receptors; reuptake; selective serotonin reuptake inhibitors, SSRIs; second-generation antipsychotics; synapse; therapeutic index; tricyclic antidepressants, TCAs. A number of factors, such as genetics, neurodevelopmental factors, drugs, infection, and traumatic experience, can interact and produce a psychiatric disorder. No matter the cause, physical changes in the brain can result in disturbances in the patient's behavior and mental experiences. These physiological alterations are the targets of the psychotropic, Greek for psyche or mind, and trepion, to turn, medications used to treat mental disease. Despite the fact that psychotropic drugs have been used for more than half a century, we do not understand how some of these drugs improve psychiatric symptoms. Early biological theories associated a single neurotransmitter with a specific disorder. Experts now view the dopamine theory of schizophrenia and the monoamine theory of depression as overly simplistic. Other neurotransmitters, hormones, and co-regulators play important and complex roles. Recent discoveries have influenced the direction of research and treatment. Before looking at specific drugs, this chapter begins with an overview of normal functions of the brain and how these functions are carried out. Theories of the psychobiological basis of various types of emotional and physiological dysfunctions are presented next. Finally, the chapter reviews the major classification of drugs used to treat mental disorders, explains how they work, and identifies both the beneficial and problematic effects of psychiatric drugs. Additionally, detailed information regarding adverse and toxic effects, nursing implications, and teaching tools are presented in the appropriate clinical chapters. Structure and function of the brain. Functions and activities of the brain. Regulating behavior and carrying out mental processes are important, but not the only responsibilities of the brain. Box 3.1 summarizes some of the major functions and activities of the brain. Box 3.1, Functions of the brain. Monitor changes in the external world. Monitor the composition of body fluids. Regulate the contractions of the skeletal muscles. Regulate the internal organs. Initiate and regulate the basic drives: hunger, thirst, sex, aggressive self-protection. Mediate conscious sensation. Store and retrieve memories. Regulate mood, affect, and emotions. Think and perform intellectual functions. Regulate the sleep cycle. Produce and interpret language. Process visual and auditory data. Maintenance of homeostasis. The brain serves as a coordinator and director of the body's response to both internal and external changes. Appropriate responses require a constant monitoring of the environment, interpretation and integration of the incoming information, and control over the appropriate organs of response. The goal of these responses is to maintain homeostasis, and therefore to maintain life. Various sense organs relay information about the external world to the brain by the peripheral nerves. Sensations such as light, sound, or touch must ultimately be interpreted as a lamp, doorbell, or a tap on the back. These sensations can be altered, particularly in psychotic disorders such as schizophrenia, where an individual experiences a sensation, such as voices, that do not originate in the external world. To respond to the external world, The brain controls skeletal muscles. This control includes the ability to initiate contraction. It also fine-tunes and coordinates contraction so that a person can, for example, guide the fingers to the correct keys on a piano. Unfortunately, both psychiatric disease and its treatment with psychotropic drugs can be associated with disturbance of movement. It is important to remember that the skeletal muscles controlled by the brain include the diaphragm, which is essential for breathing, and the muscles of the throat, tongue, and mouth, which are essential for speech. Therefore, drugs that affect brain function can stimulate or depress respiration or lead to slurred speech. The brain not only monitors the external world, but also monitors internal functions. It continuously receives information about blood pressure, body temperature, blood gases, and the chemical composition of the body fluids so that it can direct the appropriate responses required to maintain homeostasis. For example, if blood pressure drops, the brain must direct the heart to pump more blood and the smooth muscles of the arterioles to constrict. This increase in cardiac output and vasoconstriction allows the body to return blood pressure to its normal level. Regulation of the autonomic nervous system and hormones. The autonomic nervous system and the endocrine system serve as links between the brain and the cardiac muscle, smooth muscle, and glands of which the internal organs are composed. Figure 3.1. If the brain needs to stimulate the heart, it must activate the sympathetic nerves to the sinoatrial node and the ventricular myocardium. If the brain needs to bring about vasoconstriction, it must activate the sympathetic nerves to the smooth muscles of the arterioles. The homeostatic linkage between the brain and the internal organs explain why mental disturbances such as anxiety alter internal function. Anxiety can activate the sympathetic nervous system, leading to symptoms such as increased heart rate and blood pressure, shortness of breath, and sweating. The brain also influences the internal organs by regulating hormonal secretions of the pituitary gland, which in turn regulates other glands. A specific area of the brain, the hypothalamus, secretes hormones called releasing factors. These hormones act on the pituitary gland to stimulate or inhibit the synthesis and release of pituitary hormones. Once in the general circulation, they influence various internal activities. An example of this linkage is the release of gonadotropin-releasing hormone by the hypothalamus at the time of puberty. This hormone stimulates the pituitary to release two gonadotropins, follicle-stimulating hormone and luteinizing hormone, which activates the ovaries or testes. This linkage may explain why anxiety or depression, e.g., premenstrual dysphoric disorder, in some women is associated with the menstrual cycle. The relationship between the brain, the pituitary gland, and the adrenal glands is particularly important in normal and abnormal mental function. The steps in the system are: 1. The hypothalamus secretes corticotropin-releasing hormone, CRH. 2. CRH stimulates the pituitary to release adrenocorticotropic hormone. 3. Adrenocorticotropin stimulates the cortex of each adrenal gland, located on top of the kidneys, to secrete the hormone cortisol. This system is referred to as the hypothalamic pituitary adrenal axis, or HPTA. It is part of the normal response to a variety of mental and physical stressors. Figure 3.2. All three hormones, CRH, corticotropin, and cortisol, influence the functions of the nerve cells of the brain. There is considerable evidence that this system influences most psychiatric disturbances. For example, elevated cortisol levels are found in people with major depressive disorder. Elevated cortisol levels suppress the immune response and make depressed individuals more vulnerable to infection. Control of biological drives and behavior. To understand the basis of psychiatric disorders, it is helpful to distinguish between the various types of brain activity. An understanding of these activities shows where to look for disturbed function and what to hope for in treatment. The brain is responsible for such basic drives as sex and hunger. Disturbances of these drives, e.g., overeating or undereating, loss of sexual interest, can be an indication of an underlying psychiatric disorder, such as depression. Cycle of sleep and wakefulness. Various regions of the brain regulate and coordinate the entire cycle of sleep and wakefulness, as well as the intensity of alertness while the person is awake. Sleep is essential for both physiological and psychological well-being. Sleep pattern disturbances occur in virtually every psychiatric disorder. An important gauge in the process of recovery from these disorders is improvement of sleep. Drugs used to treat psychiatric problems may also interfere with the normal regulation of sleep and alertness. Drugs with a sedative hypnotic effect can reduce alertness and can cause drowsiness. These drugs require caution while engaging in activities that require a great deal of attention, such as driving a car or operating machinery. One way of minimizing the danger is to take sedating drugs at night just before bedtime. Circadian rhythms. Circadian rhythms are the fluctuation of various physiological and behavioral patterns over a 24-hour cycle. Changes in sleep, body temperature, secretion of hormones such as corticotropin and cortisol, and secretion of neurotransmitters such as norepinephrine and serotonin are influenced by these rhythms. Both norepinephrine and serotonin are thought to be involved in mood. There is evidence that the circadian rhythm of neurotransmitter secretion is altered in psychiatric disorders, particularly in those that involve mood. Conscious mental activity. All aspects of conscious mental experience and sense of self originate from the activity of the brain. Conscious mental activity can be a basic, meandering stream of consciousness that flows from thoughts of future responsibilities, memories, fantasies, and so on. Conscious mental activity can also be much more complex when it is applied to problem solving and the interpretation of the external world. Unfortunately, conscious mental experiences can become distorted in psychiatric illness. A person with schizophrenia may have chaotic and incoherent speech and thought patterns, e.g., unconnected phrases and topics, and delusional interpretations of personal interactions, such as beliefs about people or events not supported by data or reality. Memory. An extremely important component of mental activity is memory, the ability to retain and recall past experiences. From both an anatomical and a physiological perspective, there's a major difference in the processing of short and long-term memory. This can be seen dramatically in some forms of cognitive mental disorders such as Alzheimer's disease, in which a person has no recall of the events of the previous few minutes, but may have vivid recall of events that occurred decades earlier. Social skills. An important and often neglected aspect of brain functioning involves social skills that make interpersonal relationships possible. In almost all types of mental illness, from mild anxiety to severe schizophrenia, difficulties in interpersonal relationships are important parts of the disorder. As with sleep, improvements in these relationships are important gauges of recovery. Cellular composition of the brain. The brain is composed of approximately 100 billion neurons, nerve cells that conduct electrical impulses. Most functions of the brain, from regulation of blood pressure to the conscious sense of self, result from the actions of individual neurons and the interconnections between them. Although neurons come in a great variety of shapes and sizes, all carry out the same three types of physiological actions. 1. Responding to stimuli, 2. Conducting electrical impulses, and 3. Releasing chemicals called neurotransmitters. Neurons have the ability to communicate by conducting an electrical impulse from one end of the cell to the other. All cellular membranes are electrically charged due to ions inside and outside the cell. Communication between neurons occurs mainly through sodium, Na+, and potassium, K+, ions. In a resting state, there is an unequal distribution of these two on the inside of the cell membrane and on the outside. There are lots of positively charged potassium ions just inside the membrane, and lots of sodium ions, along with some potassium ions, on the outside. The intracellular space is more negative when compared with the extracellular space. Stimulation of the nerve cell membrane changes this resting state within milliseconds. First, the stimulus causes the sodium gates to open. Sodium ions flow into the nerve cells and potassium ions flow out. The entry of positively charged ions into the cell actually reverses the electrical potential from a negative one to a positive one. The current at the end of the cell is conducted along the membrane until it reaches the other end. Once an electrical impulse reaches the end of a neurotransmitter is released. A neurotransmitter is a chemical substance that functions as a neuromessenger. Neurotransmitters are released from the axon terminal at the presynaptic neuron on excitation. The neurotransmitter then crosses the space, or synapse, to an adjacent postsynaptic neuron where it attaches to receptors on the neuron's surface. It is this interaction from one neuron to another by way of a neurotransmitter and receptor that allows the activity of one neuron to influence the activity of other neurons. It is the interaction between neurotransmitter and receptor that is a major target of the drugs used to treat psychiatric disease. Table 3.1 lists important neurotransmitters and the types of receptors to which they will attach. That is a big old table. It takes up the entire page, and we will look at that later. Also listed are the mental health disorders associated with an increase or decrease in these neurotransmitters. After attaching to a receptor and exerting its influence on the postsynaptic cell, the neurotransmitter separates from the receptor and is destroyed. Box 3.2 describes the process of neurotransmitter destruction. That table takes up also almost an entire page, and we will look at that later. Neurotransmitters can be destroyed two ways. Specific enzymes destroy some neurotransmitters, e.g. acetylcholine, at the postsynaptic cell. The enzyme that destroys acetylcholine is called acetylcholinesterase, referred to as cholinesterase from here on. Most enzymes start with the name of the neurotransmitter they destroy and end with the suffix "ase." Other neurotransmitters, e.g. norepinephrine, are taken back into the presynaptic cell from which they were originally released by a process called cellular reuptake. These neurotransmitters are either reused or destroyed by intracellular enzymes. In the case of monoamine neurotransmitters, e.g. norepinephrine, dopamine, serotonin, the destructive enzyme is called monoamine oxidase, MAO. Organization of the brain. Brainstem. The most primitive area of the brain is the brainstem. It connects directly to the spinal cord and is central to the survival of all animals by controlling such functions as heart rate, breathing, digestion, and sleeping. Ascending pathways in the brainstem, referred to as mesolimbic and mesocortical pathways, seem to play a strong role in modulating the emotional value of sensory material. These pathways project to areas of the cerebrum, collectively known as the limbic system. The limbic system plays a crucial role in emotional status and psychological function, using norepinephrine, serotonin, and dopamine as their neurotransmitters. The role of these pathways is normal, and abnormal mental activity is significant. For example, experts believe that the release of dopamine from the mesolimbic pathway plays a role in psychological reward and drug addiction. The neurotransmitters released by these neurons are major targets of the drugs used to treat psychiatric disorders. Hypothalamus. In a small area above the brainstem lies the hypothalamus, which plays a vital role in controlling basic drives such as hunger, thirst, and sex, linking higher brain activities such as thought, emotion, and the functioning of the internal organs, processing sensory information that is then sent to the cerebral cortex, regulating the entire cycle of sleep and wakefulness, and the ability of the cerebrum to carry out conscious mental activity. Cerebellum. Located behind the brainstem where the spinal cord meets the brain, the cerebellum receives information from the sensory systems, the spinal cord, and other parts of the brain and then regulates voluntary motor movements. It plays a crucial role in coordinating contractions so that the movement is accomplished in a smooth and directed manner. It is also involved in balance and the maintenance of equilibrium. Cerebrum. The human brainstem and cerebellum are similar in both structure and function to these same structures in other mammals. The development of a much larger and more elaborate cerebrum is what distinguishes human beings from the rest of the animal kingdom. The cerebrum, situated on top of and surrounding the brainstem, is responsible for mental activities and a conscious sense of being. This is responsible for our conscious perception of the external world and our own body, emotional status, memory, and control of skeletal muscles that allow willful direction of movement. The cerebrum is also responsible for language and the ability to communicate. The surface of the cerebrum is called the cerebral cortex. There are 4 major lobes of the cortex, each responsible for specific functions. For example, conscious sensation and the initiation of movement reside in the frontal lobe. The sensation of touch resides in the parietal lobe. Sounds are based in the temporal lobe, and vision is housed in the occipital lobe. Likewise, a specific area of the frontal cortex controls the initiation of skeletal muscle contraction. Of course, all areas of the cortex are interconnected so that you can form an appropriate picture of the world and, if necessary, link it to a proper response. Both sensory and motor aspects of language reside in specialized areas of the cerebral cortex. Sensory language functions include the ability to read, understand spoken language, and know the names of objects perceived by the senses. Motor functions involve the physical ability to use muscles properly for speech and writing. In both neurological and psychological dysfunction, the use of language may become compromised or distorted. The change in language ability may be a factor in determining a diagnosis. Underneath the cerebral cortex are pockets of gray matter deep within the cerebrum. Some of these, the basal ganglia, are involved in the regulation of movement. Others, the amygdala and hippocampus in the limbic system, are involved in emotions, learning, memory, and basic drives. Anxiety disorders can be associated with abnormalities in the amygdala, which cause intense fear, such as in panic disorder. Significantly, there is an overlap of these areas both anatomically and in the types of neurotransmitters involved. One important consequence is that drugs used to treat emotional disturbances may cause movement disorders, and drugs used to treat movement disorders may cause emotional changes. Visualizing the brain. A variety of non-invasive imaging techniques are used to visualize brain structure, functions, and metabolic activity. Table 3.2 identifies some common brain imaging techniques and preliminary findings as they relate to psychiatry. There are 2 types of neuroimaging techniques, structural and functional. Structural imaging techniques, e.g. computed tomography, CT, and magnetic resonance imaging, MRI, provide overall images of the brain and layers of the brain. Functional imaging techniques, e.g. positron emission tomography, PET, and single photon emission computed tomography, SPECT, reveal physiological activity in the brain. PET scans are particularly useful in identifying physical and chemical changes as they occur in living tissue. For scanning the brain, a radioactive atom is applied to glucose to create a radionuclide, also referred to as a tag, because the brain uses glucose for its metabolism. In unmedicated patients with schizophrenia, PET scans may show a decreased use of glucose in the frontal lobes. Twin studies demonstrate lower brain activity in the frontal lobe of a twin diagnosed with schizophrenia compared with the twin who does not have the diagnosis. The area affected in the frontal cortex of the twin with schizophrenia is an area associated with reasoning skills, which are greatly impaired in people with schizophrenia. PET scans of individuals with depression show decreased brain activity in the prefrontal cortex. Figure 3.6 shows a patient with depression with reduced brain activity compared with someone who does not have depression. Figure 3.7 shows 3 views of a PET scan of the brain of a patient with Alzheimer's disease. Modern imaging techniques have become important tools in assessing molecular changes in mental disease and marking the receptor sites of drug action. From a psychiatric perspective, it is important to understand what areas of the brain are implicated in dysfunction. There's a little box here. Can we measure neurotransmitters? The answer is that there is no perfect or easy way to measure levels of neurotransmitters. In fact, much of what we know about neurotransmitters and brain disturbances comes from pharmacology of the drugs used to treat these conditions. For example, we knew that drugs that were effective in reducing the delusions and hallucinations of schizophrenia blocked the D2 receptors for dopamine. With this knowledge, researchers concluded that delusions and hallucinations result from overactivity of dopamine at these receptors. Diagnosis of mental illnesses are based on signs and symptoms and not quantifiable biological evidence. Change may be on the way. In 2013, the National Institute of Mental Health began an initiative called the Research Domain Criteria, RDOC, to develop a biologically valid framework for understanding mental disorders. They hope to bring together the power of modern research approaches in genetics, neuroscience, and behavioral science to the problem of mental illness. Disturbances of mental function. Most origins of mental dysfunctions are unknown. Some known causes include drugs, e.g. LSD, long-term use of highly daily doses of prednisone, excess levels of hormones, e.g. thyroxine and cortisol, infection, e.g. encephalitis or AIDS, and physical trauma. Even when the cause is known, the link between the causative factor and the mental dysfunction is difficult to understand. Genetics. There is often a genetic predisposition for psychiatric disorders. The incidence of both thought and mood disorders are higher in relatives of people who have these diseases than in the general population. Identical twins provide us with an understanding of inheritance of a disorder through a concept known as concordance rate. Concordance refers to how often an illness will affect both twins even when they are raised apart. A 100% concordance rate would mean that if one twin has a disorder, the other one would also have it. For schizophrenia, the concordance rate is 50%, meaning that inheritance is half of the equation and that other factors are involved. Neurotransmitters. Major components in the brain's chemical stew are the monoamine neurotransmitters, norepinephrine, dopamine, and serotonin, the amino acid neurotransmitters, glutamate, and Y-aminobutyric acid, or GABA, the neuropeptides, CRH and endorphin, and acetylcholine. Alteration of these chemicals is the basis of psychiatric illness and is the target for pharmacological treatment. Understanding alterations in neurotransmitters will lead to better treatments and possibly prevent mental disorders. Research interest is focused on certain neurotransmitters and their receptors, particularly in the limbic system, which links the frontal cortex, basal ganglia, and upper brainstem. Let us consider major depression. We believe that a deficiency of norepinephrine, serotonin, dopamine, or a combination of these is the biological basis of depression. How this deficiency happens is illustrated in Figure 3.8. Figure 3.8a shows normal transmission of neurotransmitters. In Figure 3.8b, we see a deficiency in the amount of neurotransmitter in the presynaptic cell. Figure 3.8c shows a deficiency or loss of the ability of postsynaptic receptors to respond to the neurotransmitters. Changes in neurotransmitter release and receptor response can be both a cause and a consequence of intracellular changes in the neurons involved. Thought disorders, such as schizophrenia, are associated with excess transmission of dopamine from the presynaptic neuron. As illustrated in Figure 3.9, this may be caused by excessive release of the neurotransmitter or to an increase in receptor responsiveness. Besides dopamine, the neurotransmitter glutamate may have a role in schizophrenia's pathology. Glutamate may have a direct influence on the activity of dopamine-releasing cells. First, glutamate activity increases in the hippocampus, then hippocampus metabolism is increased, and then the hippocampus begins to atrophy or shrink the brain's memory center. This process happens early in the disease and may become a primary tool for early diagnosis and a target for treatment. The neurotransmitter GABA seems to play a role in modulating neuronal excitability and anxiety. Not surprisingly, many anti-anxiety anxiolytic drugs act by increasing the effectiveness of this neurotransmitter. This is accomplished primarily by increasing receptor responsiveness. It is important to keep in mind that a vast network of neurons interconnects the various areas of the brain. This network serves to integrate the many activities of the brain. A limited number of neurotransmitters are used in the brain, and thus a particular neurotransmitter is often used by different neurons to carry out quite different activities. For example, dopamine is not only involved in thought processes, but also the regulation of movement. As a result, alterations in neurotransmitter activity resulting from a mental disturbance or to the drugs used to treat the disturbance can affect both thinking and movement. Basic body processes, such as sleep patterns, body movement, and autonomic functions, can be affected by alterations in mental status, whether arising from disease or from medication. Action of psychotropic drugs. Two essential concepts to understand when studying drugs are pharmacodynamics and pharmacokinetics. Pharmacodynamics is fairly straightforward. It is the study of what drugs do to the body and how they do it. It includes drug action and drug responses. Both the action and responses are dose-related. The term pharmacokinetics comes from two Greek words, pharmakon, drugs, and kinesis, motion. As these words imply, pharmacokinetics is the movement of a drug through the body. Four basic processes of pharmacokinetics, which determine the concentration of a drug at its sites of action, are easily remembered with the acronym ADME. A. Absorption. How is the drug absorbed into the blood? D. Distribution. How is it distributed in the body? M. Metabolism. How is the drug transformed for use in excretion? E. Excretion. How does the body excrete it? An understanding of pharmacokinetics helps maximize the drug's benefit while minimizing harm. The benefits are derived by achieving a high enough level of the drug at the site of action, while minimizing harm by using the lowest possible dose. Pharmacokinetics helps us choose the most effective route, dosage, and schedule. Pharmacokinetics and pharmacodynamics are impacted by genetic factors that give rise to inter-individual and cross-ethnic variations in drug response. The Considering Culture box discusses how the area of pharmacogenetics influences the way healthcare providers tailor their prescriptions for patients. The liver metabolizes most drugs into active metabolites, chemicals that also have pharmacological actions. Researchers use this knowledge in designing new drugs that make use of the body's own mechanisms to activate a chemical for pharmacological use. An ideal psychiatric drug would relieve the mental disturbance of the patient without inducing additional cerebral, mental, or somatic physical effects. Unfortunately, in psychopharmacology, as in most areas of pharmacology, there are no drugs that are both fully effective and free of undesired side effects. Researchers work toward developing medications that target the symptoms while producing fewer side effects. Because all activities of the brain involve actions of neurons, neurotransmitters, and receptors, These are the targets of pharmacological intervention. Most psychotropic drugs act by either increasing or decreasing the activity of certain neurotransmitter receptor systems. Drug agonism and antagonism. Two important terms that you will see in connection with many of the psychotropic drugs are agonist and antagonist. The word agonist comes from the Latin word agonista, that means contender. Agonist drugs mimic the effect of neurotransmitters naturally found in the human brain by binding to and stimulating the receptor site. The word antagonist is derived from the Latin word antagonista, that means adversary or opponent. Rather than binding to and stimulating the receptor site, drugs with antagonistic properties block the neurotransmitters, thereby obstructing the neurotransmitter's action. Anti-anxiety and hypnotic drugs. The major inhibitory calming neurotransmitter in the central nervous system, CNS, is GABA. The most commonly used anti-anxiety agents are the benzodiazepines. Benzodiazepines potentiate or promote the activity of GABA by binding to a specific receptor on the GABA receptor complex. This binding results in an increased frequency of chloride channel opening, causing membrane hyperpolarization, which reduces the cellular excitation. If cellular excitation is decreased, the result is a calming effect. Figure 3.10 shows the benzodiazepines such as diazepam, Valium, clonazepam, Klonopin, and alprazolam, Xanax, enhance the effects of GABA. All benzodiazepines can cause sedation at higher therapeutic doses. There are 5 benzodiazepines approved by the FDA for treatment of insomnia with a predominantly hypnotic, sleep-inducing effect. Flurazepam, Dalmane, temazepam, Restoril, triazolam, Halcyon, estazolam, Prosom, and quazepam, Doral. Other benzodiazepines, such as lorazepam, Ativan, and alprazolam, Xanax, reduce anxiety without being as sleep-producing when used at lower therapeutic doses. The fact that benzodiazepines inhibit neurons probably accounts for their usefulness as anticonvulsants and for their ability to reduce the neuronal overexcitement of alcohol withdrawal. When used alone, even at high dosages, these drugs rarely inhibit the brain to the degree of respiratory depression, coma, and death. However, when combined with other CNS depressants such as alcohol, opiates, or tricyclic antidepressants, the inhibitory actions of the benzos can lead to life-threatening CNS depression. Any drug that inhibits electrical activity in the brain can interfere with motor ability, attention, and judgment. Healthcare providers must caution a patient taking benzos about engaging in activities that could be dangerous if reflexes and attention are impaired, including specialized activities such as working in construction and more common activities such as driving a car. In older adults, the use of benzodiazepines may contribute to falls and bone fractures. Ataxia is a common side effect secondary to the abundance of GABA receptors in the cerebellum. Short-acting sedative hypnotic sleep agents. The Z-hypnotics include zolpidem, Ambien, Zaloplan, Sonata, and Ezopiclone, or Lunesta. They have sedative effects without the anti-anxiety, anticonvulsant, or muscle relaxant effects of benzodiazepines. They are selective for GABA-A receptors containing alpha-1 subunits. The drug's affinity to alpha-1 subunits confers a potential for amnestic and ataxic side effects, and their onset of action is faster than that of most benzodiazepines. It is important to inform patients taking non-benzodiazepine hypnotic agents about the quick onset of action and to take them when they are ready to go to sleep. Most of these drugs have short half-lives, which determine the duration of action. Azopiclone has the longest duration of action, an average of 7 to 8 hours of sleep per therapeutic dose, while the other two are much shorter. Azopiclone also has a unique side effect of an unpleasant bitter taste upon awakening. Although tolerance and dependence are reportedly less than with benzos, the Z-hypnotics are categorized as Schedule 4, similar to benzos, by the US DEA. There have been reports of sleepwalking, eating, and even driving after the use of Z-hypnotics. These CNS adverse effects have been reported with other hypnotics as well. Doses for immediate release zolpidem are now lower for women and the elderly. Melatonin receptor agonists. Melatonin is a naturally occurring hormone that is only excreted at night as part of the normal circadian rhythm. Rameltion, or Razarem, is a melatonin receptor agonist and acts much the same way as endogenous melatonin. It has a high selectivity and potency at the MT1 receptor site, which regulates sleepiness, and at the MT2 receptor site, which regulates circadian rhythms. This is one of 2 hypnotic medications approved for the treatment of insomnia, not classified as a scheduled substance. Lacking abuse potential by the DEA. Side effects include headache and dizziness. Long-term use of Rameltion above therapeutic doses can lead to increased prolactin and associated side effects, e.g. sexual dysfunction. Doxepin. Doxepin, or Cellular, is a low-dose formulation, 3 mg and 6 mg tablets, of an old tricyclic antidepressant. Doxepin is indicated for the treatment of insomnia, characterized by difficulty in maintaining sleep. The mechanism of action for its sedative effect is most likely from a strong histamine 1 receptor blockade. Patients with severe urinary retention or on MAOIs should avoid this medication. The use of other CNS depressants and sedating antihistamines should also be avoided. Doxepin was mainly studied in the geriatric population, where it showed an improvement in total sleep duration with no significant decrease in time of sleep onset. Suvoroxant. The orexins are neurotransmitters produced in the hypothalamus that promote normal wakefulness. Suvoroxant, or Belsomra, is an orexin receptor antagonist. It selectively blocks the binding of orexin to suppress wakefulness. There are some important precautions, including daytime impairment, e.g. falling asleep while driving, additive CNS depression when used together with other CNS depressants, abnormal thinking and behavioral changes, worsening depression or increases in suicidal ideation, sleep paralysis, hypnagogic and hypnopompic hallucinations, cataplexy-like symptoms associated with the higher doses. Those are definitely all words. Buspirone. Buspirone, or Buspar, is a drug that reduces anxiety without having strong sedative hypnotic properties. Because this agent does not leave the patient sleepy or sluggish, patients tolerate it better than the benzos. It is not a CNS depressant and therefore does not have as great a danger of interaction with other CNS depressants such as alcohol. Although the mechanism of action of buspirone is not clear, one possibility is illustrated in Figure 3.11. Buspirone seems to act as a partial serotonin 1A agonist booster. It also has a moderate affinity for D2 receptors, and side effects include dizziness and insomnia. Refer to Chapter 15 on anxiety disorders for discussion of the adverse reactions, dosages, nursing implications, and patient and family teaching points for the anti-anxiety drugs. Refer to Chapter 19 on sleep disorders for a more detailed discussion on medications to promote sleep. Treating anxiety disorders with antidepressants. The symptoms, neurotransmitters, and circuits associated with anxiety disorders overlap extensively with those of depressive disorders. Many antidepressants have proven to be effective treatments for anxiety disorders. SSRIs are often used to treat obsessive-compulsive disorder, OCD, social anxiety disorder, SAD, generalized anxiety disorder, GAD, panic disorder, PD, and post-traumatic stress disorder, PTSD. The selective serotonin norepinephrine reuptake inhibitor, SNRI, venlafaxine, Effexor XR, is used to treat GAD, SAD, and PD. Another drug in that classification, duloxetine or Cymbalta, has FDA approval for GAD. Antidepressant drugs. Our understanding of the neurophysiological basis of mood disorders is far from complete. However, a great deal of evidence indicates that the neurotransmitter norepinephrine and serotonin play a major role in regulating mood. A transmission deficiency of one or both of these monoamines within the limbic system may underlie depression. One piece of evidence is that all of the drugs that demonstrate efficacy in the treatment of depression increase the synaptic level of one or both of these neurotransmitters. Figure 3.12 identifies the side effects of specific neurotransmitters being blocked or activated. Figure 3.13 illustrates the normal release, reuptake, and destruction of monoamine neurotransmitters. A grasp of this underlying physiology is essential for understanding how the antidepressant drugs act. Hypotheses of antidepressants' mechanism of action are: 1. The monoamine hypothesis of depression suggests that there is a deficiency in one or more of the three neurotransmitters, serotonin, norepinephrine, or dopamine. The theory implies that by increasing these neurotransmitters, depression is alleviated. The monoamine receptor hypothesis of depression also suggests that low levels of neurotransmitters cause postsynaptic receptors to be upregulated, increasing in sensitivity or number. Increasing neurotransmitters by antidepressants results in downregulation, desensitization, of key neurotransmitter receptors. Delayed length of time for downregulation may explain why it takes 4 to 6 weeks for antidepressants to work, especially if they rapidly increase neurotransmitters. 2. Another hypothesis for the mechanism of antidepressant drugs suggests that with prolonged use, they increase production of neurotrophic factors. These factors regulate the survival of neurons and enhance the sprouting of axons to form new synaptic connections. SSRI. As the name implies, the SSRIs, such as fluoxetine, Prozac, sertraline, Zoloft, paroxetine, Paxil, citalopram, Celexa, escitalopram, Lexapro, and fluvoxamine, Luvox, block the reuptake of serotonin, thereby making more of this neurotransmitter available. However, they each have slightly different effects. Fluoxetine, Prozac, is a serotonin 5-HT2C antagonist, which can lead to the anorexic and antibulimic effects of fluoxetine at higher doses. Both sertraline, Zoloft, and fluvoxamine, Luvox, have sigma-1 receptor binding property. Researchers do not completely understand sigma-1 action, but believe it contributes to anxiety-reducing and antipsychotic actions. Paroxetine, Paxil, is the most anticholinergic among the SSRIs due to its muscarinic 1 antagonist property. Although it is relatively less anticholinergic than the tricyclic antidepressants, paroxetine may not be the best choice for patients with contraindications to anticholinergic agents, e.g., narrow-angle glaucoma. Citalopram, Celexa, has R and S enantiomers. At lower dosages, the R isomer may inhibit the increased 5-HT effects of the S isomer, leading to inconsistent efficacy. Escitalopram, or Lexapro, has the S enantiomer structure only without the R enantiomer, which explains its more predictable efficacy in lower doses. Holy shit, I'm back in chemistry class. Alright, as a class, SSRIs have less ability to block the muscarinic and histamine receptors than do the tricyclic antidepressants. As a result of their more selective action, they seem to show comparable efficacy without causing the anticholinergic and sedating side effects. However, SSRIs have other side effects resulting from stimulation of different serotonin receptors. Stimulation of the 5-HT2A and 5-HT2C receptors in the spinal cord may inhibit the spinal reflexes of orgasm. Stimulation of the 5-HT2A receptors in the mesocortical area may decrease dopamine activity in this area, leading to apathy and low libido. Stimulation of the 5-HT3 receptors in the hypothalamus or brainstem may cause nausea or vomiting, while GI side effects are secondary to the 5-HT3 and or 5-HT4 receptors in the GI tract. Whew. All right. Norepinephrine and serotonin-specific antidepressant. The class of drugs known as norepinephrine and serotonin-specific antidepressant, NASSA, is represented by only one drug, mirtazapine, Remeron, which increases norepinephrine and serotonin transmission by antagonizing, blocking, presynaptic alpha-2 adrenergic autoreceptors. Mirtazapine offers both anti-anxiety and antidepressant effects with minimal sexual dysfunction and improved sleep. This antidepressant causes fewer GI symptoms. The most common side effects are sedation, appetite stimulation, and weight gain. Norepinephrine dopamine reuptake inhibitor. Bupropion, or Wellbutrin, is an antidepressant also used for smoking cessation, Zyban. It seems to act as a norepinephrine dopamine reuptake inhibitor, NDRI, with no serotonergic activities. It does not cause sexual dysfunction side effects. Side effects include insomnia, tremor, anorexia, and weight loss. It is contraindicated in patients with a seizure disorder, in patients with a current or prior diagnosis of bulimia or anorexia nervosa, and in patients undergoing abrupt discontinuation of alcohol or sedatives, including benzos, due to potential of seizures. Serotonin antagonist and reuptake inhibitors. Nefazodone, formerly sold as Cerzone, is a novel drug indicated only for depression. It is a serotonin antagonist and reuptake inhibitor, SARI, that works by blocking serotonin receptors and weakly inhibiting the reuptake of norepinephrine and serotonin. The most common side effects are sedation, headache, fatigue, dry mouth, nausea, constipation, dizziness, and blurred vision. Weight gain and sexual dysfunction are minimal. This drug should be used with caution due to life-threatening liver failure and should never be given to people with pre-existing liver problems. Trazodone, formerly sold under the trade name Deserel, was not used for antidepressant treatment for many years. It was often given, along with another agent, for the treatment of insomnia, as sedation is one of its common side effects. A trademarked version, Aleptro, has FDA approval as an extended-release drug indicated for the use of major depressive disorder in adults. Its antidepressant effects are due to its action as a 5-HT reuptake inhibitor and 5-HT2A/2C antagonist. Common side effects of trazodone are sedation, dizziness, and orthostatic hypotension. Potent alpha-1 antagonists with little anticholinergic effects, such as trazodone, can lead to priapism, a painful, prolonged erection caused by the inability for detumescence, subsidence of erection. Brexpiprazole Rexulti was introduced in 2015. It has FDA approval as a treatment for the depression that accompanies schizophrenia. It works as a partial agonist at serotonin 5-HT1A and dopamine D2 receptors and antagonist activity at serotonin 5-HT2A receptors. Due to dopamine effects, it may result in akathisia. Weight gain is also a side effect of this drug. In case you're wondering what akathisia is, it's a movement disorder characterized by a subjective feeling of inner restlessness accompanied by mental distress and an inability to sit still. Serotonin modulator and stimulator. Vortioxetine, or Trintellix, is a serotonin modulator and stimulator. It affects many different serotonin receptors by inhibiting serotonin reuptake, like SSRIs, agonizing the 5-HT1A receptor, like buspirone, partially agonizing the 5-HT1B receptor, and antagonizing the 5-HT3, 5-HT1D, and 5-HT7 receptors. Geriatric patients may experience an improvement of cognitive deficits independent of its antidepressant properties. Common side effects include constipation, nausea, and vomiting. More serious side effects are hyponatremia and rarely induction of hypomania or mania. Lovely. Serotonin norepinephrine reuptake inhibitors. SNRIs increase both serotonin and norepinephrine. Venlafaxine, Effexor, acts more like a serotonergic agent at lower therapeutic doses and promotes norepinephrine reuptake blockade at higher doses, leading to the dual SNRI action. Hypertension may be induced in about 5% of patients and is a dose-dependent effect based on norepinephrine reuptake blockade. Doses greater than 150 milligrams a day can increase diastolic blood pressure by approximately 7 to 10 milligrams mercury. Desvenlafaxine, or Pristiq, is the primary active metabolite of venlafaxine. When people take venlafaxine, the majority of the benefit comes from venlafaxine being metabolized into desvenlafaxine. Therefore, the mechanism of action and effects of the two antidepressants are similar. Duloxetine, or Cymbalta, is an SNRI indicated for both depression and GAD, as well as diabetic peripheral neuropathy, fibromyalgia, and chronic musculoskeletal pain. Like the tricyclic antidepressants, many of the SNRIs also have therapeutic effects on neuropathic pain. The common underlying mechanism of neuropathic pain is nerve injury or dysfunction. The mechanism by which tricyclic antidepressants and SNRIs reduce neuropathic pain is activating the descending norepinephrine and 5-HT pathways to the spinal cord. thereby limiting pain signals from reaching the brain. The previously discussed SNRIs inhibit serotonin reuptake more than they inhibit norepinephrine reuptake. Levomilnacipran, or Fetzima, is an SNRI with a greater effect on norepinephrine reuptake than any of the other SNRIs available for treating depression. Increasing norepinephrine may be responsible for observed increases in heart rate and blood pressure in some patients. Serotonin partial agonist and reuptake inhibitor. Vilazodone, or Vibrid, is an antidepressant approved by the FDA in 2011. It enhances the release of serotonin by inhibiting the serotonin transporter, similar to SSRIs, and by stimulating serotonin, 5-HT1A. Receptors through partial agonism, similar to the anti-anxiety medication buspirone. That was the end of the sentence. With this dual activity, vilazodone is considered to be a serotonin partial agonist and reuptake inhibitor, SPARI. Commonly observed adverse reactions during clinical trials include diarrhea, nausea, insomnia, and vomiting. Patients should take this antidepressant with food for better bioavailability and avoid nighttime doses due to insomnia. Alright, only a few pages left. Tricyclic antidepressants were widely used before the development of SSRIs. They are no longer considered first-line medications since they have more side effects, take longer to reach an optimal therapeutic dose, and are far more lethal in overdose. The TCAs act primarily by blocking the reuptake of norepinephrine for the secondary amines, e.g. nortriptyline, Pamelor, and both norepinephrine and serotonin for the tertiary amines, e.g. amitriptyline, imipramine, tofranil. As shown in figure 3.15, this blockade prevents norepinephrine from coming into contact with its degrading enzyme, MAO, increasing the level of norepinephrine at the synapse. Similarly, the tertiary TCAs block the reuptake and destruction of serotonin and increase the synaptic level of this neurotransmitter. To varying degrees, many of the tricyclic drugs also block the muscarinic acetylcholine receptors. As discussed in the previous section, this blockade leads to anticholinergic effects such as blurred vision, dry mouth, tachycardia, urinary retention, and constipation. These adverse effects can be troubling to patients and limit their adherence to the regimen. Depending on the individual drug, these agents can also block histamine 1, H1, receptors in the brain. Blockade of these receptors by any drug causes sedation and drowsiness, an unwelcome symptom in daily use. Persons taking TCAs often have adherence issues because of their adverse reactions. TCA overdose can be fatal, secondary to cardiac conduction disturbances from excessive sodium channel blockade. MAOIs are a class of antidepressant drugs that can have a desired effect in the brain while exerting potentially dangerous effects elsewhere. To understand the action of these drugs, keep in mind the following definitions. Monoamines are organic compounds. Monoamines include the neurotransmitters norepinephrine, epinephrine, dopamine, serotonin, and many other food substances and drugs. MAO is an enzyme that destroys monoamines. MAOIs are drugs that inhibit the action of MAO to prevent the destruction of monoamines. MAOIs increase the synaptic level of neurotransmitters, resulting in the antidepressant effect of these drugs. Examples of MAOIs include isocarboxazid, Marplan, phenylazine, Nardil, selegiline, MSAM, and tranylcypromine, or parnate. There's a problem with inhibiting MAO. The liver uses these enzymes to degrade monoamine substances that enter the body from food. One monoamine, tyramine, is present in most protein-based foods. However, some foods are extremely rich in tyramine. They include aged cheeses, pickled or smoked fish, and wine. If the liver cannot break down the tyramine from these substances, tyramine can produce significant vasoconstriction. This vasoconstriction results in an elevation in blood pressure and the threat of a hypertensive crisis. In addition to food, a number of drugs, such as other antidepressants and sympathomimetic drugs, can result in serious reactions. In a patient taking drugs to inhibit MAO, the blood level of monoamine drugs can reach high levels and cause serious toxicity. Any drug that amplifies serotonin, e.g. an antidepressant, or norepinephrine, e.g. amphetamines, is at risk for a hypertensive crisis due to an excess supply of these neurotransmitters. For example, paroxetine, or Paxil, inhibits the reuptake of serotonin, making more serotonin available. At the same time, if MAO is inhibited and is not degrading the serotonin as quickly, dangerous levels of serotonin can occur. Patients should avoid using some over-the-counter products with sympathomimetic properties, e.g. oral decongestants, or serotonergic properties, e.g. dextromethorphan. Because of the dangers that result from inhibition of hepatic and intestinal MAO, patients taking MAOIs must be given a list of foods and drugs to avoid. Chapter 14 discusses the treatment of depression and contains a list of foods to avoid and foods to be taken in moderation, along with nursing measures and instructions for patient education. Mood stabilizers. Lithium. Although lithium, escalith, or lithobid, has been used as a mood stabilizer in patients with bipolar, manic depressive disorder, for many years, we do not understand its mechanism of action. As a positively charged cation, similar in structure to sodium and potassium, lithium may well act by affecting electrical conductivity in neurons. As discussed earlier, an electrical impulse consists of the inward depolarizing flow of sodium followed by an outward repolarizing flow of potassium. These electrical charges are propagated along the neuron so that if they are initiated at one end of the neuron, they will pass to the other end. Once they reach the end of a neuron, a neurotransmitter is released. It may be that an overexcitement of neurons in the brain underlies bipolar disorder, and lithium interacts in some complex way with sodium and potassium at the cell membrane to stabilize electrical activity. Furthermore, lithium may reduce the excitatory neurotransmitter glutamate and exert an antimanic effect. Another mechanism by which lithium functions to regulate mood includes the non-competitive inhibition of the enzyme inositol monophosphatase. Inhibition of 5-HT autoreceptors by lithium is more related to lithium's antidepressant effects rather than its antimanic effects. While we do not know exactly how lithium works, we are certain that its influence on electrical conductivity results in adverse effects and toxicity. By altering electrical conductivity, lithium represents a potential threat to all body functions regulated by electrical currents, especially cardiac contraction. Lithium can induce, although not commonly, sinus bradycardia. Extreme alteration of cerebral conductivity with overdose can lead to convulsions. Alteration in nerve and muscle conduction can commonly lead to tremor at the therapeutic doses or more extreme motor dysfunction with overdose. Sodium and potassium play a strong role in regulating fluid balance, and the distribution of fluid in various body compartments explains the disturbances in fluid balance that lithium can cause. These include polyuria, the output of large volumes of urine, and edema, the accumulation of fluid in the interstitial space. Long-term use of lithium can cause hypothyroidism in some patients, which is secondary to interfering with the iodine molecules affecting the formation and conversion to its active form, T3 thyroid hormone. In addition, hyponatremia can increase the risk of lithium toxicity because increased renal reabsorption of sodium leads to increased reabsorption of lithium as well. Primarily because of its effects on electrical conductivity, lithium has a low therapeutic index. The therapeutic index represents the ratio of the lethal dose to the effective dose and is a measure of overall drug safety in regard to the possibility of overdose or toxicity. A low therapeutic index means that the blood level of a drug that can cause death is not far above the blood level required for drug effectiveness. Lithium blood levels need to be monitored on a regular basis to ensure that the drug is not accumulating and rising to dangerous levels. Table 3.3 lists some of the adverse effects of lithium. Chapter 13 considers lithium treatment in more depth and discusses specific dosage-related adverse and toxic effects, nursing implications, and the patient teaching plan. Anti-convulsant drugs. Valproate, available as divalproic sodium depakote and valproic acid depakine, and also carbamazepine or Tegretol, and lamotrigine or Lamictal, are all useful in the treatment of bipolar disorders. Their anticonvulsant properties derive from the alteration of electrical conductivity in membranes. In particular, they reduce the firing rate of very high-frequency neurons in the brain. It is possible that this membrane-stabilizing effect accounts for the ability of these drugs to reduce the mood swings that occur in patients with bipolar disorders. Other proposed mechanisms as mood stabilizers are glutamate antagonists and GABA agonists. Valproate. Valproate, depakote or depakine, is structurally different from other anticonvulsants and psychiatric drugs that show efficacy in the treatment of bipolar disorder. Valproate is recommended for mixed episodes and has been found useful for rapid cycling. Common side effects include tremor, weight gain, and sedation. Occasional serious side effects are thrombocytopenia, pancreatitis, hepatic failure, and birth defects. Baseline levels are measured for liver function tests and complete blood count before an individual is initiated on this medication, and laboratory monitoring is repeated periodically. In addition, the therapeutic blood level of the drug is monitored. Carbamazepine, also known as Equetro or Tegretol, is useful in treating acute mania. It reduces the firing rate of overexcited neurons by reducing the activity of sodium channels. Baseline liver function tests, CBC, electrocardiogram, and electrolyte levels should be obtained. Blood levels are monitored to avoid toxicity, which is greater than 12 micrograms per milliliter. But there are no established therapeutic blood levels for carbamazepine in the treatment of bipolar disorder. Common effects include anticholinergic side effects, e.g. dry mouth, constipation, urinary retention, blurred vision, orthostasis, sedation, and ataxia. A rash may occur in about 10% of patients during the first 20 weeks of treatment. This potentially serious side effect should be reported immediately because it could progress to a life-threatening exfoliative dermatitis or Stevens-Johnson syndrome. In case you're wondering, Stevens-Johnson syndrome is a type of severe skin reaction. Together with toxic epidermal necrolysis and Stevens-Johnson toxic epidermal necrolysis, it forms a spectrum of disease, with SJS being less severe. And I'm looking at a picture of it here, and it looks horrible and nasty. Okay, the FDA requires genetic testing before this drug is used in people of Asian descent. Okay. Lamotrigine. The FDA approved lamotrigine, or Lamictal, for maintenance therapy in bipolar disorder, but it is not effective in acute mania. Lamotrigine works well in treating the depression of bipolar disorder. It modulates the release of glutamate and aspartate. Patients should promptly report any rashes, which could be a sign of life-threatening Stevens-Johnson syndrome. This adverse drug reaction can be minimized by slowly increasing to therapeutic doses. Concurrent use with valproate may double the blood levels of lamotrigine and increase the risk of Stevens-Johnson syndrome. Antipsychotic drugs. First-gen antipsychotics are also referred to as conventional antipsychotics and typical antipsychotics. An overactivity of the dopamine system in the mesolimbic system may be responsible for at least some of the symptoms of schizophrenia. These drugs are strong antagonists, blocking the action, of the D2 receptors for dopamine. By binding to these receptors and blocking the attachment of dopamine, they reduce dopaminergic stimulation. These drugs may be most effective on the positive symptoms of schizophrenia, such as delusions, e.g. paranoid and grandiose ideas, and hallucinations, e.g. hearing or seeing things not present in reality. These drugs are also antagonists, to varying degrees, of the muscarinic receptors for acetylcholine, alpha-1 receptors for norepinephrine, and H1 receptors for histamine. Although it is unclear if the antagonism plays a role in the beneficial effects of the drugs, it is certain that antagonism is responsible for some of their major side effects. Figure 3.17 illustrates the proposed mechanism of action of the first-generation antipsychotics, which includes the phenothiazines, thioxanthines, butyrophenones, and pharmacologically related agents. As summarized in Figure 3.18, many of the unpleasant side effects are logical given their receptor blocking activity. For example, because dopamine, D2, in the basal ganglia plays a major role in the regulation of movement, it is not surprising that dopamine blockade can lead to motor abnormalities known as extrapyramidal symptoms, EPS. These EPS include acute dystonic reactions, Parkinsonism, akathisia, and tardive dyskinesia. Nurses and physicians often monitor patients for evidence of involuntary movements after administration of the first-generation antipsychotic agents. One popular scale is called the Abnormal Involuntary Movement Scale, or AIMS. Refer to Chapter 12 for an example of AIMS and a discussion of the clinical use of antipsychotic drugs, side effects, specific nursing interventions, and patient teaching strategies. An important physiological function of dopamine is that it acts as a hypothalamic factor that inhibits the release of prolactin from the anterior pituitary gland. Therefore, blockade of dopamine transmission can lead to increased pituitary secretion of prolactin. In women, the hyperprolactinemia can result in amenorrhea, absence of the menses, or galactorrhea, excessive or inappropriate breast milk production. And in men, it can lead to gynecomastia, development of the male mammary glands, and galactorrhea. Ooh. Acetylcholine is a neurotransmitter that attaches to muscarinic receptors and helps regulate internal function. Blockade of the muscarinic receptors by phenothiazines and a wide variety of other psychiatric drugs can lead to a constellation of adverse effects. These side effects usually involve blurred vision, dry mouth, constipation, and urinary hesitancy. These drugs can also impair memory, since acetylcholine is important for memory function. Many of the first-generation antipsychotic drugs also act as antagonists for norepinephrine. These receptors are found on smooth muscle cells that contract in response to norepinephrine from sympathetic nerves. For example, the ability of sympathetic nerves to constrict blood vessels is dependent on the attachment of norepinephrine to alpha-1 receptors. Therefore, blockade of these receptors can bring about vasodilation and a consequent drop in blood pressure. Vasoconstriction, mediated by the sympathetic nervous system, is essential for maintaining normal blood pressure when the body is in the upright position. Blockade of the alpha-1 receptors can lead to orthostatic hypotension. Finally, many of these first-generation antipsychotic agents, as well as a variety of other psychiatric drugs, block the H1 receptors for histamine. The two most significant side effects of blocking these receptors are sedation and substantial weight gain. Sedation may be beneficial in severely agitated patients. Non-adherence to the medication regimen is a significant issue because of these troublesome side effects. Second-generation antipsychotics are also known as atypical antipsychotics. These drugs produce fewer EPS and target both the negative and positive symptoms of schizophrenia. These newer agents are often chosen as first-line treatments over the first-generation antipsychotics due to a more favorable side effect profile. Most of the available second-gen antipsychotics, however, can increase the risk of metabolic syndrome with increased weight, blood glucose, and triglycerides. The simultaneous blockade of receptors 5-HT2C and H1 is associated with weight gain from increased appetite stimulation via the hypothalamic eating centers. Strong anti-muscarinic properties at the M3 receptor on the pancreatic beta cells can cause insulin resistance, leading to hyperglycemia. The receptor responsible for elevated triglycerides is currently unknown. Clozapine and olanzapine have the highest risk of causing metabolic syndrome, while aripiprazole and ziprasidone are among the lowest risk in this classification. The second-generation antipsychotics are predominantly D2 dopamine and 5-HT2A serotonin antagonists blockers. The blockade at the mesolimbic dopamine pathway decreases psychosis, similar to the way the first-generation antipsychotics work. Decreasing D2 stimulation can decrease psychosis, but cause adverse effects in the nigrostriatal area, which can cause the movement side effects of EPS, mesocortical area, which can worsen cognitive and negative symptoms of schizophrenia, tuber-oinfundibular area, which can increase the hormone prolactin, leading to gynecomastia, galactorrhea, amenorrhea, and low libido. Most second-gen antipsychotics have more 5-HT2A than D2 antagonist effects. Blocking the 5-HT2A receptors increases dopamine and norepinephrine. This may explain why the second-generation antipsychotics have less effect on causing EPS, cognitive impairment, and prolactin effects. Clozapine. Clozapine, or Clozaril, is an antipsychotic drug that is relatively free of the motor side effects of the phenothiazines and other second-generation antipsychotics. Clozapine preferentially blocks the D1 and D2 receptors in the mesolimbic system rather than those in the nigrostriatal area. This allows it to exert an antipsychotic action without leading to difficulties with EPS. However, it can cause a potentially fatal side effect. Clozapine has the potential to suppress bone marrow and induce agranulocytosis. Any deficiency in white blood cells renders a person prone to serious infection. Therefore, regular measurement of the absolute neutrophil count, ANC, is necessary. Typically, the count is measured weekly for the first 6 months. If results are normal, counts will be measured every other week for the next 6 months and every month thereafter. Clozapine has the potential for inducing convulsions, a dose-related side effect, in 3.5% of patients. Patients should use caution with other drugs that can increase the concentration of clozapine. Note that smoking cessation reduces CYP1A2 enzymes and can increase clozapine's concentration. Risperidone. Risperidone, or Risperdal, has a low potential for inducing agranulocytosis or convulsions. However, high therapeutic dosages, more than 6 milligrams per day, may lead to motor difficulties. As a potent D2 agonist, it has the highest risk of EPS among the second-gen antipsychotics and may increase prolactin, which may lead to sexual dysfunction. Because risperidone blocks A1 and H1 receptors, it can cause orthostatic hypotension and sedation, respectively. Keep in mind that orthostatic hypotension can lead to falls, which are a serious problem among older adults. Weight gain, sedation, and sexual dysfunction are adverse effects that may affect adherence to the medication regimen and should be discussed with patients. Risperdal Consta is an injectable form of the drug that is administered every 2 weeks, providing an alternative to the depot form of first-gen antipsychotics. Quetiapine, or Seroquel, has a broad receptor binding profile. Its strong blockade of H1 receptors accounts for the high sedation. The combination of H1 and 5-HT2C blockade leads to the weight gain associated with use of this drug and also to a moderate risk for metabolic syndrome. It causes moderate blockade of alpha-1 receptors and associated orthostasis. Quetiapine has a low risk for EPS or prolactin elevation from low D2 binding due to rapid dissociation at D2 receptors. This drug is too commonly prescribed for sleep problems when other drugs should be considered. Olanzapine, or Zyprexa, is similar to clozapine in chemical structure. It is an antagonist of 5-HT2, D2, H1, alpha-1, and muscarinic receptors. Side effects include sedation, weight gain, hyperglycemia with new onset type 2 diabetes, and higher risk for metabolic syndrome. Olanzapine is also available in a long-acting intramuscular agent under the trade name Zyprexa Relprev. Ziprasidone, or Geodon, is a serotonin norepinephrine reuptake inhibitor at multiple receptors, 5-HT2, D2, alpha-1, and H1D. Ziprasidone is contraindicated in patients with a known history of QT interval prolongation, recent acute myocardial infarction, or uncompensated heart failure. Each dose should be taken with food to enable absorption. For those wondering what QT interval prolongation is, in long QT syndrome, your heart's electrical system takes longer than normal to recharge between beats. This delay, which often can be seen on an EKG, is called a prolonged QT interval. Aripiprazole, or Abilify, is a unique second-gen antipsychotic known as a dopamine modulator in addition to its 5-HT2A antagonist activity. Depending on endogenous dopamine levels and signaling status, aripiprazole has varying effects on the D2 receptor due to its partial agonist properties. In areas of the brain with excess dopamine, it lowers the dopamine level by acting as a receptor antagonist. However, in regions with low dopamine, it stimulates receptors to raise the dopamine level. Aripiprazole lacks H1 and 5-HT2C properties, which explains its lack of sedation and weight gain, respectively. Paliperidone, or Invega, is the major active metabolite of risperidone. It has similar side effects with regard to prolactin elevation. Other than the D2 and 5-HT2A antagonistic properties as an antipsychotic, paliperidone is also an antagonist at alpha-1 receptors and H1 receptors, which explains the side effects of orthostasis and sedation, respectively. The osmotic release oral system, or OROS, provides consistent 24-hour release of the medication, leading to minimal peaks and troughs in plasma concentrations. It also has two long-acting injectable formulas, Invega Sustenna every month and Invega Trinza every 3 months. Iloperidone, or Fanapt, possesses minimal binding affinity for H1 receptors and has minimal affinity for cholinergic muscarinic receptors. A common adverse effect is orthostatic hypotension from alpha-1 blockade, which necessitates a slow dosage titration over the first few days to minimize orthostatic hypotension. There was a significant increase in the mean QT interval, although no deaths or serious arrhythmias were noted in the clinical trials. Another limitation of this medication is the risk of orthostatic hypotension. Lurazidone, or Latuda, has high affinity for 5-HT2A and D2 receptors in addition to other serotonergic receptors such as 5-HT1A. Lurazidone has similar pharmacological properties to the tetracyclic antidepressant mirtazapine. Lurazidone has high affinity for serotonergic such as 5-HT2A and 5-HT2C, noradrenergic, and dopaminergic receptors, D3 and D4. There is minimal muscarinic receptor activity. Each dose must be taken with 350 calories to ensure optimal absorption. Asenapine, or Safris, is unique among the antipsychotics as being administered in a sublingual formulation, which enhances its direct absorption. Therefore, it avoids much of the hepatic metabolism that restricts its availability when administered orally. Bioavailability of asenapine is reduced from 35% with sublingual administration to less than 2% with oral administration. Patients should avoid food and water for 10 minutes after sublingual administration. It has a higher affinity for 5-HT2A receptors than D2 receptors. It also has antagonistic activity at alpha-1 receptors that accounts for the orthostatic hypotension, and H1 antagonistic activity, which causes sedation. Chapter 12 discusses the first and second generation antipsychotic drugs in detail, including the indications for use, adverse reactions, nursing implications, and patient and family teaching. Drug treatment for attention deficit hyperactivity disorder. Children and adults with ADHD show symptoms of short attention span, impulsivity, and overactivity. Paradoxically, psychostimulant drugs are the mainstay of treatment for this condition in children and increasingly in adults. Both methylphenidate, Ritalin, or Daytrana, a transdermal system, and dextroamphetamine, Adderall and Vyvanse, are helpful in these conditions. They are sympathomimetic amines and have been shown to function as direct and indirect agonists at adrenergic receptor sites. Psychostimulants act by blocking the reuptake of norepinephrine and dopamine into the presynaptic neuron and increasing the release of these monoamines into the synapse. How this translates into clinical efficacy is far from understood, but it is thought that the monoamines may inhibit an overactive part of the limbic system. Among many concerns with the use of psychostimulant drugs are side effects of agitation, exacerbation of psychotic thought processes, hypertension, and growth suppression, as well as their potential for abuse. The FDA has approved 3 non-stimulants for the treatment of ADHD: atomoxetine, Strattera, guanfacine, Intuniv, and clonidine, Capvey. Atomoxetine is a norepinephrine reuptake inhibitor approved for use in children 6 years or older. Common side effects include decreased appetite and weight loss, fatigue, and dizziness. It is contraindicated for patients with severe cardiovascular disease due to its potential to increase blood pressure and heart rate. Guanfacine and clonidine are centrally acting alpha-2 adrenergic agonists that have traditionally been used for hypertension. The FDA-approved forms for ADHD are used in children ages 6 to 17. Both should be increased slowly and should not be discontinued abruptly. Guanfacine's most common side effects include sleepiness, low blood pressure, nausea, stomach pain, and dizziness. The drug's effectiveness with teenagers is questionable and probably works best in preteens. Clonidine extended-release tablets can be used alone or in addition to other ADHD drugs. Common side effects include fatigue, irritability, throat pain, insomnia, nightmares, emotional disorder, constipation, increased body temperature, dry mouth, and ear pain. Drug treatment for Alzheimer's disease. The insidious and progressive loss of memory and other higher brain functions brought about by Alzheimer's disease is a great individual, family, and social tragedy. Because the disease seems to involve progressive structural degeneration of the brain, there are 2 major pharmacological directions in its treatment. The first is to attempt to prevent or slow the structural degeneration. Although actively pursued, this approach has been unsuccessful so far. The second is to attempt to maintain normal brain function for as long as possible. Much of the memory loss in this disease has been attributed to insufficient acetylcholine, a neurotransmitter essential for learning, memory, and mood, and behavior regulation. One class of drugs for Alzheimer's disease, cholinesterase inhibitors, shows some efficacy in slowing the rate of memory loss and even improving memory. They work by inactivating the enzyme that breaks down acetylcholine, cholinesterase, leading to less destruction of acetylcholine and therefore a higher concentration at the synapse. 4 of the FDA-approved drugs for treatment of Alzheimer's disease are cholinesterase inhibitors: tacrine or Cognex, donepezil or Aricept, galantamine or Razidine, formerly named Remenil, and rivastigmine, Exelon or Exelon patch. Tacrine is no longer used extensively because of the risk of hepatic toxicity. All of these drugs are used for mild to moderate Alzheimer's disease. Donepezil and the Exelon patch are for the mild to severe form of the disease. All of them become less effective as the brain produces less acetylcholine. Glutamate, an abundant excitatory neurotransmitter, plays an important role in memory function. However, too much glutamate can be destructive to neurons. A 5th agent approved by the FDA for treatment of Alzheimer's disease is memantine or Namenda and Namenda XR, an extended-release formulation named for the receptor it blocks from glutamate N-methyl D-aspartate, NMDA. Normally, when glutamate binds to NMDA receptors, calcium flows freely and is essential to cell communication. However, pathological gray tangles of amyloid protein that build up in Alzheimer's brains, or amyloid plaques, are associated with excess glutamate. This excess receptor stimulation by glutamate results in excess calcium, which becomes toxic to surrounding brain cells. Memantine fills some of the NMDA receptor sites, reduces glutamate binding and calcium excess, and reduces damage. Memantine has become effective in the treatment of moderate to severe Alzheimer's disease, since memantine has a very different mechanism of action than the cholinesterase inhibitors. They can be taken at the same time. Refer to Chapter 23 for a more detailed discussion of these drugs, as well as the nursing considerations and patient and family teaching. Almost done. Herbal treatments. There are a variety of factors that drive the growing interest in medicinal herbs. Many people believe that herbal treatments are safer because they are natural, or that they may have fewer side effects than more costly traditional medications. Herbal treatments have been researched to understand their mechanisms of action and have also been used in clinical trials to determine their safety and efficacy. This is especially true of St. John's wort. Many medicinal herbs have been found to be non-therapeutic, and some even deadly if taken over long periods of time or in combination with other chemical substances and prescription drugs. The risk of bleeding may be increased in patients taking ginkgo biloba and warfarin, and kava may increase the risk of hepatotoxicity. Chapter 36 covers complementary and integrative approaches in more detail. And that is it. What a monster of a chapter, but we got through it.